palpebral conjunctiva, bulbar conjunctiva, fornical conjunctiva. Okay, there are three types of conjunctiva in our eye. So conjunctiva is basically the outer layer of the eye. So in this diagram, as you can see, first of all we'll study about the palpebral conjunctiva. This is the tightly adhered layer of the conjunctiva, tightly adhered layer of the conjunctiva. Okay, which is tightly adhered to the tarsal plates. Okay, so here in this diagram you can see this is the palpebral conjunctiva. Okay, this is the palpebral conjunctiva. And second one, it is a bulbar conjunctiva. It is loosely adhered. It is loosely adhered over the sclera. Okay, loosely adhered over the sclera. So in this diagram you can see this is the bulbar conjunctiva, which is loosely adhered. Okay, and between these palpebral conjunctiva and the bulbar conjunctiva lies the fornical conjunctiva in the fornix. Okay, in the fornix. So this is the fornical conjunctiva. Okay, so next, now the layers of conjunctiva. The layers of the conjunctiva. There are basically two layers of conjunctiva. Two layers of conjunctiva. First one is the epithelium. First one is the epithelium. Epithelium in conjunctiva is pseudo-stratified. Columnar epithelium. Okay. And second layer is known as substantia propria. Second layer is known as substantia propria. So substantia propria has further two layers. First layer is known as adenoid layer. It has lymphoid follicles in it. Right. Second layer of the substantia propria is fibrous layer. Which has connective tissue in it. Okay. So there are two layers of conjunctiva, epithelium and substantia propria. Epithelium is pseudostratified columnar epithelium, and in substantia propria there are two layers. First one is adenoid layer and second is the fibrous layer. Okay, so histology I have already told. Histology I have already told you. It is pseudo-stratified columnar epithelium. It is 5 to 6 layers thick. Base is formed by the columnar layer, columnar epithelium, and above the columnar epithelium lies wing cells. Okay, and on the top of wing cells there is pseudo-stratified epithelium. Fine. So over the conjunctiva and the cornea there lies a tear film. So basic function of the tear film is to lubricate the eye. So it functions, it allows a smooth movement of the eyelid over the conjunctiva. So then, and also it allows the clear environment for the cornea to see, and also it provides nutrition to the cornea, as cornea is avascular structure. Cornea is avascular structure. Cornea is a avascular structure, so it helps to provide the nutrition to the cornea. Okay, so there are three layers of tear film. Okay, from inside to out there are three layers. First one is a mucus layer. Second one is the aqueous layer. Third one is the lipid layer, which is present on the outermost side of the tear film. Okay, now the mucus layer. It is secreted by goblet cells of the conjunctiva. Okay, goblet cells of the conjunctiva, and so the most abundant goblet cells are present on the inferior nasal side of the bulbar conjunctiva. It has most number of goblet cells for the secretion of the tear film. Now the aqueous layer. It is secreted by two types of glands, lacrimal glands and accessory lacrimal glands. Okay, can anyone tell me the name of two accessory lacrimal glands that are present in our eye? Two accessory lacrimal glands. Just hold on. Hello. So there are two accessory lacrimal glands, glands of Cross and glands of Wolfram. Okay, so they both help in the secretion of the aqueous layer. Now here comes the lipid layer. So can anyone tell me which structure secretes the lipid layer of the tear film? Any idea, any guess? So it is the meibomian gland. Okay, meibomian gland in the eyelid, it secretes the lipid layer of the tear film, right? So what are the functions of tear film? This I have already discussed with you, but just for the sake of completion I'll write lubrication of the eyelid, smooth lubrication of the eyelid, clarity and nutrition to the cornea. Okay, now there are various pathologies of the conjunctiva. So first of all we'll be dealing with the conjunctivitis. Okay, now can anyone tell me with what complaints can the patient of conjunctivitis can come to us? Okay, so just tell me with what complaints the patient of the conjunctivitis can come to us. Discharge, redness, chemosis, irritation. Okay, Now when the patient have come to us, now we have to examine the patient. Actually, in conjunctivitis, all the type of conjunctivitis have almost same kind of same kinds of symptoms, but the gravity of the symptoms, grading of the symptoms can vary according to the etiology of the disease. But on examination of the conjunctiva, we can have follicles over the conjunctiva, or we can have papillae over the conjunctiva. Okay, so what are the follicles? Now can you people just tell me what you can see in this diagram? In this diagram you can see there are elevated lesions present. Okay, there are elevated lesions present in the conjunctiva, in the fornical conjunctiva. So follicles are elevations in the conjunctiva having lymphoid germinal centers. Okay, lymphoid germinal centers. They do not have any blood vessels. Blood vessels will pass over the follicles like this. Okay, like this. They do not have blood vessels in their structure, in contrast to the papillae, which have blood vessels. Their papillae have have core made of fibrovascular tissue. Okay, core made of fibrovascular tissue. Papillae has core made of fibrovascular tissue. Okay, so papillae are hyperplastic conjunctiva with fibrovascular tissue in the core. Okay, now there are various etiologies of conjunctivitis, and so this is a difficulty to understand which disease will have follicular presentation and which disease will have a papillary presentation. So here I'll make you understand that which disease will have follicular presentation and which disease will have papillary presentation. Okay, so whenever you see follicles on the conjunctiva, so foremost three diagnoses that should come to your mind, they should be chlamydial conjunctivitis. Okay, any drug or toxin intake, any use of drugs. Now can anyone tell me which are the topical drugs that can cause follicular conjunctivitis? Just tell me if you can. These are cycloplegics, miotics, and anti-glaucoma drugs. All these drugs can cause follicular type of conjunctivitis. Okay, third one is the molluscum contagiosum. Caused by pox virus. Okay, now bacteria they mostly cause the papillary type of conjunctivitis. Okay, bacteria they cause papillary conjunctivitis, but there are two exceptions to it. What are those two exceptions? First one is the Moraxella, second one is Bartonella. So conjunctivitis caused by these two bacterial etiologies, they will have a follicular presentation. Okay, and all the viral conjunctivitis, they will have a follicular type of presentation. Okay, now patient will also come to us with the complaint of discharge. So there are various kind of discharge with which patient can come to us. Watery discharge, mucoid discharge. Okay, purulent discharge, and mucopurulent discharge. Okay, just hold on. Okay, now just tell me what are the causes of watery discharge. So viral etiologies will have a watery kind of a discharge. Mucoid, allergic causes. Purulent, bacterial causes, and mucopurulent, bacterial, in which gonococcus and meningococcus are the two main causes of mucopurulent discharge. Okay, right? So now adenoviral conjunctivitis. So this adenoviral conjunctivitis is a viral conjunctivitis. Now you have to just tell me, adenovirus is a DNA virus or a RNA virus? Okay, just tell me fast, is this a DNA virus or a RNA virus? So this is a DNA virus, double stranded DNA virus. So mainly conjunctivitis, if we'll talk about the conjunctivitis of viral etiologies, adenovirus is the most common cause of conjunctivitis of viral etiology. Okay, so there are three types of presentation of the adenoviral conjunctivitis. First one is the follicular conjunctivitis. Second is the pharyngoconjunctival fever. And third is epidemic keratoconjunctivitis, also known as EKC. So follicular conjunctivitis is, in this only there will be follicles present in the conjunctiva. Okay, only follicles. Okay, pharyngoconjunctival fever, as is evident from the name itself, it will have a systemic presentation also. The patient can have pharyngitis, patient can have fever, and patient will have conjunctivitis also. Okay, now you have to tell me what are the serotypes of adenovirus that can cause pharyngoconjunctival fever. Okay, just any guesses? Anyone who can tell me? So there are three serotypes, 3, 4 and 7. These three serotypes causes pharyngoconjunctival fever. And now yes, Krish, you are right, 3, 4, 7, it causes pharyngoconjunctival fever. Now just tell me epidemic keratoconjunctivitis serotypes involved in this. It is 19, 8 and 37. Okay, 19, 8 and 37. So in this, as it is evident from the name, it is more severe than pharyngoconjunctival fever. In this, patient will have URTI, conjunctivitis, and also patient will have keratitis. Okay, in keratitis, patient will have subepithelial infiltrates. Okay. Yes, Krish, you are right. 8, 19 and along with 37. Okay. Now, treatment of adenovirus. Okay. We'll have to give lubricants to the patient. Okay, preservative free lubricants to avoid toxins. Okay, to avoid adverse effects of the preservative that are present in the lubricants. Okay, if patient have corneal involvement, then you can give steroids. Only then you have to give steroids. Okay. Otherwise, in follicular conjunctivitis and pharyngoconjunctival fever, steroids are not much needed. Okay, in EKC. Okay, NSAIDs can also be given. Okay, and in EKC, patient can also come to us with membrane formation. Okay, so removal of the membrane has also have to be done in treatment for epidemic keratoconjunctivitis. Now, anyone can tell me the difference between true membranes and false membranes? Anyone, please. Can anyone just tell me? False membrane, they will not bleed. They will not bleed on removal. Okay, they will not bleed, they will bleed on removal. So this is the main difference. Okay, so if at all membranes are present, so in membrane removal can also be done as a part of treatment in epidemic keratoconjunctivitis. Okay, now acute hemorrhagic conjunctivitis. Yes, Krish, you are right. They bleed on peeling. Okay. Now, acute hemorrhagic conjunctivitis. Now, can anyone tell me the causes of acute hemorrhagic conjunctivitis? Causes of acute hemorrhagic conjunctivitis. These are enterovirus and Coxsackie virus. Yes, Krish, Coxsackie and enterovirus. Okay, enterovirus and the Coxsackie virus. And for the clinical feature, they are more or less same as that of adenoviral conjunctivitis. Okay, same as of adenoviral conjunctivitis. Okay. Now, coming on to the chlamydial conjunctivitis. Okay, so first of all, I would like to tell you something about the structure of chlamydia. Okay, can anyone tell me to what class of chlamydia belong? Bacteria. Chlamydia are bacteria which have no cell wall.
Playing from 1+7.
Hello? वो मैंने खोल लिया YouTube पे, खोल लिया iPad पे. मैंने आईपैड खोल लिया, मैंने आईपैड पे चल रहा है, फ़ोन पे बाद में बताऊँगी, ठीक है. So chlamydia, it is a bacteria which have no cell wall. So there are two types of bodies in chlamydia, okay. Elementary body and reticular body, okay. This is extracellular, this is intracellular, okay. Elementary part of the chlamydia, it is infective. So whenever infection occurs due to chlamydia, it is due to the elementary bodies, okay. Now there are three types of serotypes in chlamydia, okay. There are three types of serotypes: A to C, D to K, and L1 to L3, okay. Now can anyone just tell me A to C serotypes causes what disease? A to C serotypes of chlamydia causes what type of disease? Anyone? Come on guys, answer. D to K serotypes causes adult inclusion conjunctivitis. Yes, and L1 to L3 causes lymphogranuloma venereum, okay. So in ophthalmology, we are basically concerned about these two, trachoma and adult inclusion conjunctivitis, okay. So let us study something about adult inclusion conjunctivitis. So in this, patient will have a history of urinary tract infection also. Along with the conjunctivitis, patient can have history of urinary tract infection, okay. So in males, epididymitis, and in females, urethritis can be present, okay. Now treatment of adult inclusion conjunctivitis will mainly give lubricants in this, okay. Now come on to the trachoma. Trachoma, I just want to tell you that it used to be a major public health problem, but now trachoma has been eliminated. Trachoma now has been eliminated, okay. Active trachoma has been eliminated. Active trachoma has been eliminated, but not the complications, okay, not the complications. So can anyone tell me the risk factors involved in trachoma? Can anyone just tell me the risk factors which are involved in trachoma? These are poor living conditions, overcrowding. Trachoma is basically a disease of poor, okay. So overcrowding, poor living conditions, poor hygiene, all these can lead to trachoma, okay. Come on people, you have to participate also in the discussion. You are not answering. please put your answer in the chat box along with me. Okay. Transmission. Fly act as a vector for trachoma transmission. Okay. Fly acts as a vector for trachoma transmission. Now clinical features. Now can anyone just tell me with what clinical features patient of trachoma will present to us? Patient can come to us with inactive trachoma. Patient can comes to us with discharge, redness. Okay, and on examination, what all we can find in trachoma patients? We can find scarring over the cornea. Now you have to just tell me, trachoma, it is a follicular type of, it will have a follicular type of conjunctivitis or a papillary type of conjunctivitis. I have already told you this thing. Yes, follicles. Very good, Krish. It will have follicles. Okay. Patient can come to us with trichiasis also. Entropion of the lower lid. Okay. Can anyone tell me the definition of entropion? Anyone? Entropion is inward turning of the eyelid. Yes, Herbert pits are also there. It is inward turning of the eyelid. Herbert pits. Okay. Scarring. Okay. So there is one staging. So in this clinical features, can anyone tell me what is this line? There is this whitish band present over the upper palpebral conjunctiva. Can anyone just tell me what is this line known as? This is known as Art's line. Art's line. And what are these? These are Herbert pits, and these are follicles which are present over the upper palpebral conjunctiva. Okay, so there is follicles in trachoma have a characteristic name. Can anyone tell me that name of the follicles in trachoma? Characteristic appearance, I will say. They have a characteristic appearance. Sago grain appearance. They will have a sago grain appearance. Okay. Now staging for the conjunctiva, staging for the trachoma. Now there is a Fisto staging. Now can anyone tell me the Fisto staging for trachoma? Follicular stage, inflammation, scarring, trichiasis, and opacity. Okay. Fisto staging has these features. Okay. Follicles, more than 5 5 or more than 5 follicles should be present. Okay, and in this vascularization is present, inflammation is present, and it obscure the details of underlying vessels. Okay, it should be to such extent that it should obscure the details of underlying vessels. Okay, scarring, arch line is present. Okay, trichiasis, it is inward turning of the eyelashes. Okay, trichiasis is the inward turning of the eyelashes. So even one trichiatic lash, if the patient is having even one trichiatic lash, that is considered in the fistostaging. Okay, and when there is inward turning of the lashes, it causes rubbing over the cornea and causes corneal opacity. It causes rubbing over the cornea and causes opacity. Okay, so that is all for the fistostaging. Now government has devised various plans and various strategies for the elimination of the trachoma. So one of them is safe strategy. Can anyone tell me the full form of safe strategy? Anyone? Godappa, can you please tell me? It is not mass. Yes, mass immunization is there. That stands for A. A is antibiotics. Okay, you are right, Godappa. What does S stands for? F and E. Now you people have to tell me S, F and E. Yes, Krish, it is safe, but you have to tell me what does S stands for. No idea. S stands for surgery for trichiasis. Okay, or for opacity in the cornea. For trichiasis in eyelid or for opacities in cornea. A stands for antibiotics. Can anyone tell me which antibiotics do we use? Can anyone tell me the antibiotic? Yes, F is facial. Yes, very good, Krish. F is facial cleanliness. And E is environmental hygiene. Okay, environmental hygiene. Now, treatment of trachoma. Treatment, I have already told you the antibiotic that we use in treatment of trachoma. It is azithromycin. Now can anyone tell me the dose of azithromycin? Anyone? Yes, Krish, tetracycline is also used. First tell me the dose of azithromycin. In adults, it is 1 gram per day. And in children, it is 20 mg per kg. Tetracycline, they can also be used. Tetracyclines can also be used. But there are one contraindications of tetracycline. There are some contraindications of tetracycline. Can anyone tell me? Pregnant ladies, lactating females, and children. So avoid tetracycline in these patients. Okay. So this is a broad treatment of trachoma. Okay. Now coming on to the bacterial conjunctivitis. So in bacterial conjunctivitis we can have acute bacterial conjunctivitis and hyperacute bacterial conjunctivitis. Okay, now you have to just tell me the risk factors for acute bacterial conjunctivitis. Risk factors for acute bacterial conjunctivitis. It is trauma. Okay. Trauma, it is the main cause of acute bacterial conjunctivitis. Any ocular disease, any underlying ocular disease, okay. And can anyone tell me the cause of hyperacute bacterial conjunctivitis? Hyperacute bacterial conjunctivitis. Can anyone just tell me? It is gonococcus. Okay. As I have already told you that clinical features of the conjunctivitis, they are more or less same in every etiology, but the severity, or we can say grading, it varies according to the etiology. So clinical features: discharge, redness, chemosis, stickiness, irritation. So these are all the clinical features of bacterial conjunctivitis. Now treatment. For treatment we can have broad spectrum antibiotics. Like third generation cephalosporins, quinolones, macrolides. So topical eye drops has to be used. Okay, topical eye drops has to be used along with lubricants. Okay, along with lubricants. Now coming on to the Ophthalmia neonatorum. It is discharge or infection in newborn baby. Okay, what is the timeline for Ophthalmia neonatorum? Till what duration of the infection we'll call it as a Ophthalmia neonatorum? Till what duration? Can anyone tell me the duration? Till 1 month. So after 1 month of the birth, if there is infection in the eye, then we'll call it as a Ophthalmia neonatorum. Okay. Now causative agents of Ophthalmia neonatorum. Yes, Dr. Yash, can you just tell me the causes of Ophthalmia neonatorum? Chemical, Krish, Godappa, Dr. Yash, please tell me the causative agents of Ophthalmia neonatorum. It can be chemical, it can be gonococcal, okay, it can be other bacterial cause like staph or any other bacteria, okay, it can be chlamydia, it can be any other viral cause, okay, viral cause like herpes simplex, herpes zoster virus. So there is also a timeline for these causes, okay, till what duration this can be the cause of ophthalmia neonatorum? Can anyone just tell me the duration? It is 2 to 3 days. Okay, if ophthalmia neonatorum is occurring in the first 2-3 days of the birth, then cause can be chemical. Okay, if it is occurring till first week, then cause can be gonococcal. If it is occurring in the later half of first week, then cause can be staph or any other bacteria. If it is occurring in 2 weeks, then cause can be chlamydia, 1 to 2 weeks. But if it is occurring after 3 weeks, 3 to 4 weeks, then cause can be viral. Now I just want to tell you one thing, that all these etiologies I have already discussed with you. So the symptoms will more or less be the same that I have discussed. But one major thing I want to tell you, that I have told you chlamydia and viral, they have follicles as sign. Okay, but follicles, they are absent in ophthalmia neonatorum. Can anyone tell me the reason for it? Why follicles are absent in ophthalmia neonatorum? Because infants have poor immunity. So that's why follicles are not there in ophthalmia neonatorum. Rest of sign and symptoms like discharge, redness, chemosis, all of them will be present, but follicles will not be there. Okay. Now, prevention of ophthalmia neonatorum. What can we give for the prevention of ophthalmia neonatorum? Can anyone please tell me? Krish, Dr. Yash. Can anyone just tell me what can we give for prevention of ophthalmia neonatorum? Povidone iodine, silver nitrate 1%. Povidone iodine and silver nitrate can be given for the prevention of ophthalmia neonatorum, and treatment, it is according to the etiology. And treatment for all these etiology I have already discussed with you. Antivirals, mainly acyclovir. Okay, for chlamydia it is azithromycin, and for bacteria cephalosporins and quinolones. Okay, so this is a treatment for ophthalmia neonatorum. Okay, now coming on to the allergic conjunctivitis. In allergic conjunctivitis also we will study two types of allergic conjunctivitis, AKC and VKC. So what is the full form of VKC? Yes, Adyut Prakash, can you just tell me the full form of VKC? It is vernal keratoconjunctivitis. Okay, and AKC, it is atopic keratoconjunctivitis. So these are type of hypersensitivity reactions. Okay, etiology of allergic conjunctivitis is hypersensitivity reaction. Can anyone just tell me which type of hypersensitivity reaction occurs in AKC and VKC? Which type of hypersensitivity reactions occur in AKC and VKC? Adyut Prakash. Okay, just now Adyut Prakash, now you have to just tell me the risk factors for VKC. In which season it occurs? What are the risk factors? What are the predisposing conditions the patient can have in VKC? Okay, don't know. So risk factors, mainly patient can have a history of atopy. Okay, history of atopy is present, may be present, and it mainly occurs in summer seasons. Okay, males are more predisposed than females. Males are more predisposed than females. VKC, there is one more synonym for VKC. Can anyone just tell me? VKC is also known as, yes, dust, pollen, molds. They are all risk factors for allergic conjunctivitis. Can anyone just tell me what is the other name of VKC? Adit Prakash, it is not spring. Spring is a misnomer. That is, I want to tell, it is known as spring catarrh, but it doesn't occur in spring season. Okay, it occur in summer season. Although its name has spring catarrh in it, spring in his name, but the etiology is but it occurs in summer season. Okay, not in spring. Okay, so there are 3 forms of VKC. Adyut, Krish, can you just tell me the 3 forms of VKC? Okay. First one is a palpable form, can have a conjunctival or limbal form, or it can have a corneal form. So, is this a papillary type of conjunctivitis or a follicular type of conjunctivitis? I have already told you which kind of disease will have a follicular type of presentation. Now you have to just tell me that is it a papillary form or a follicular form? Yes, Krish, very good. It is a papillary type of conjunctivitis. Papillary type of conjunctivitis. It is there in lower lid. Mainly lower lid will have papillae. Okay. And the patient can have a ropey discharge. Ropey discharge. Irritation. Okay. Basically itching. Patient can come to us with itching, with complaint of itching, and there are spots present on the limbal. There are spots present on the limbus. Can anyone just tell me the name of those spots? Anyone? These are Horner-Tranta spots. Okay. And in cornea, patient can have a shield ulcer. Patient can have a shield ulcer. Now, how does this shield ulcer forms? Now, you have to just understand one thing, that papillae, they are present over the conjunctiva, and they continuously keep on rubbing the cornea. Okay, and when they keep on rubbing the cornea, they create an epithelial defect over the cornea, over which mucus and plaques get deposited, leading to the formation of a shield ulcer. Okay. So I'm just revising with you. 3 forms: palpebral form, limbal or the bulbar form, and third one is the corneal. Okay. So now coming on to the AKC. AKC, it is also a type 1 hypersensitivity reaction. Also involves type 1 hypersensitivity reaction. Risk factors and all these are same as that of VKC. History of atopy can be present. But one differentiating feature from VKC is that it mainly occurs in adult population. Okay. In adult population. And it is more severe. It is more severe than VKC. Okay. So clinical features, they are all almost same as that of VKC, that is discharge, irritation, redness and itching. Okay. Now here I just want to highlight the difference between AKC and VKC. Okay, I just want to highlight the difference between AKC and VKC. Now you people have to tell me the difference between these two conditions. Okay, first one is the age group. In which age group does AKC occurs and in which age group does VKC occurs? Yes, pseudogerontoxone can also be present in VKC. I just want pseudogerontoxone. I'll just explain what is pseudogerontoxone. Now, as Adyut, you have asked me pseudogerontoxone, you have to just first tell me what is gerontoxone. Now you will only tell me what is gerontoxone. What does gerontoxone stands for? Stands for arcus senilis in cornea. Okay, arcus senilis in cornea, it is known as gerontoxone. So pseudo means it is a false gerontoxone which occurs in VKC. Okay, which occurs in VKC. So in this there is paracentral scarring. Paracentral scarring in VKC causes whitish opacity in cornea. Okay, so that looks like a gerontoxone to us, but it is in real is pseudo, so not caused by arcus senilis, so known as pseudogerontoxone. Okay, so that's why known as pseudogerontoxone. Okay, now you have to tell me the age groups for AKC and VKC. Just tell me the age groups for AKC and VKC. Anyone? I have already told you for the AKC. Just come on fast. Adult population in AKC and in younger population till 10 years of age in VKC. Okay. Hypersensitivity reaction, they are both same in AKC and VKC. It is type 1 in both. Okay. Now vision loss, किस में ज़्यादा होगा, AKC में या VKC में? Is more in AKC, less in VKC. And site of involvement. Come on people, fast. Dr. Ashwani, please tell me the site of AKC and site of VKC, site of involvement. In AKC, it can be both upper lid plus lower lid. Okay, but in VKC, it is mainly upper lid. Okay, it is mainly upper lid in VKC. And complications, they are more in AKC. More in AKC, less in VKC. Okay, these are like cataract, pannus formation. Okay, and symblepharon. They all will occur more in AKC and they are not reported in VKC. Okay, they are not reported in VKC. Now you have to now we'll discuss the treatment of allergic conjunctivitis. We'll discuss the treatment of allergic conjunctivitis. First one is the lubricants. Be it any patient of conjunctivitis, lubricants we have to definitely give. Okay, try to give preservative free lubricants. Okay, now anti-allergics. So there are two classes of anti-allergics that we can use in AKC and VKC. Can anyone just tell me the two classes that we can use? Krish, pannus is not same as not same as that of corneal vascularization. Okay, corneal vascularization is presence of new vessels, but pannus, it is presence of new vessels along with some infiltrates. Okay, so pannus can have pannus will have infiltrates along with vascularization also. Okay, now just tell me the treatment of allergic conjunctivitis. Mast cell stabilizers and antihistaminics. Okay, can anyone tell me the mast stabilizer? Yes, Krish, just tell me the mast stabilizer which we can use. Name of mast stabilizer. I want the name. Okay. Yes, Krish, welcome. So, sodium chromoglycate is mast cell stabilizer, and antihistaminics, bipostatin. Come on, this is pharmacology, you should know it. Okay, bipostatin, amidestin. Okay, now combination of both mast cell stabilizers plus antihistaminics. Can anyone just tell me the drug which is a combination of mast cell stabilizer and antihistaminics? It is olopatadine. Okay, it is olopatadine. Okay, third class of drug is steroid. Not given in the milder form, given in moderate and severe form. Moderate to severe forms will give steroids. Okay, low potency steroids like fluoromethanol we can give, and immunosuppressants in very severe conditions. Okay, immunosuppressants in very severe conditions like cyclosporin and tacrolimus. I am not going into the details of these drugs because this is not required at your level, but still I will ask the class of drugs to which these two drugs belong. To which these two drugs belong. These are calcineurin inhibitors. Okay, calcineurin inhibitors. Okay. Yes, Krish, FML we can give along with lotipred also we can give. Lotipred we can also give. Both these are steroids. Okay, both these are steroids. Okay. Yes, Krish, you are right. Tacrolimus and cyclosporin, they belong to calcineurin class, calcineurin inhibitor class. Okay, of the immunosuppressants, right? Yes. Now here is one more type of conjunctivitis known as superior limbic conjunctivitis. Now you people have to tell me the risk factors for superior limbic conjunctivitis. Risk factors for superior limbic conjunctivitis. Just tell me. It is female, more common in female than males. Underlying thyroid etiology, hyperthyroidism can be there, or KCS, keratoconjunctivitis sicca. Okay, if these three conditions are present, so they act as a risk factor for superior limbic conjunctivitis. Okay. So what exactly happens in superior limbic conjunctivitis? It is that due to thyroid ophthalmopathy occurs in the patient due to excess thyroid secretion. So due to proptosis, the upper lid of the eye, it rubs on the conjunctiva. Upper lid of the eye rubs over the conjunctiva. Okay, so it leads to redundant conjunctiva. Superior bulbar conjunctiva gets redundant. Okay. So this is kind of a loose tissue of conjunctiva hanging over the cornea. Okay, loose conjunctiva hanging over the cornea. Okay, so it will just hang over the upper superior limbus. Okay, it will just hang over the superior limbus, and it is devitalized. Okay, due to the constant rubbing by the upper lid, it get devitalized and it get stained by rose bengal stain. It gets stained by rose bengal stain as they stain the devitalized tissue. Okay, so the patient can have papillae over the upper eyelid. Okay, patient can have papillae, patient will have a redundant conjunctiva, and patient can have filaments. Patient can have filaments over the superior cornea due to the constant rubbing of the lid over the conjunctiva and cornea. Okay, patient will have filaments. So what does this filaments made up of? These filaments are made up of epithelium and mucus. So their one end is attached to epithelium and mucus. Okay, their one end is attached to the cornea. So for example, this is the cornea. Okay, this is the cornea, and they are like present like this. Their one end is attached to the cornea only. Okay, the other ends keep on flowing like this, and when the lid covers it, it causes irritation over here. Okay, it causes irritation over here in this area when this lid covers over it. Okay, so what is the treatment? Treatment is lubricants. Treatment is lubricants and anti-allergics for papillae. Okay, and if it is more severe, we have to treat the thyroid ophthalmopathy. Thyroid ophthalmopathy also. Okay, we have to treat the underlying thyroid ophthalmopathy also. Fine. Now pterygium. This is the most important and the easiest thing in the conjunctiva. Okay, now you have to just tell me the definition of pterygium. Okay, definition of pterygium. Yes, Krish, Adyut, tell me the definition of pterygium. It is elastotic degeneration of subepithelial connective tissue of the conjunctiva. Okay, yes, you are right, Adyut. It is a fibrovascular tissue from conjunctiva approaching the cornea. Right, exactly right. Now anyone can just tell me why it is known as elastotic? Why not elastic? Okay, we could have also written elastic here, but we are writing here elastotic. Why? Why elastotic? Because it is stained by, because it is it can be digested by elastase, but cannot be stained by the enzyme by which elastics usually stain. Okay, it can be digested but cannot be stained. Okay, now coming on to the risk factors for pterygium. Risk factors: it is sunlight exposure, excessive sunlight exposure. Yes, farmers are more predisposed to it because they work in sunlight. UV radiation. Okay, smoking and P53 mutation. So these are all the risk factors for pterygium. Okay, these are all the risk factors for pterygium. Now, what clinical features can pterygium have? With what complaints the patient of pterygium will comes to us? Welcome, Tanya. Now, Tanya, please tell me what are the clinical features of pterygium? With what complaints patient of pterygium can come to us? Yes, it is lacrimation, irritation, and decreased vision. Why decreased vision? Can anyone tell me the cause for decreased vision? Yes, very good, Krish. It is astigmatism. Decreased vision is due to astigmatism because as the conjunctival tissue approaches the cornea, it creates astigmatism in the cornea. Okay, it creates astigmatism in the cornea, which is the cause for decreased vision. Okay, so these are the main symptoms of pterygium. Now this is the pterygium. You can see the picture of pterygium. Now there are 3 parts of pterygium. Can anyone tell me the 3 parts of pterygium? Anyone? Yes, Ashwani Vijayan, please tell me the 3 parts of pterygium. It is cap, body and tail. Okay, cap, body and tail. Yes, you can say head also. Cap, body and tail. So this one is the cap, this one is the cap, this one is the body, and this one is the tail. Okay, this one is the tail of conjunctiva. Now head. Now body, it is that part of the pterygium which is present over the cornea and firmly attached and present over the cornea, firmly attached and vascular also. And this tail part, it is loosely attached. Okay, this is loosely attached and it is present over the conjunctiva. Now there is one line which is present ahead of the cap. Can anyone just tell me the name of that line? Anyone? Shivam, can you tell me the name of that line which is present over the cap, which is present ahead of the cap? Just tell me the name of that line. Yes, very good, Krish. It is Stocker's line. What does Stocker's line contain? Stocker line में क्या होता है? Yes, iron. Very good, Adyut. It contains iron. Okay, Stocker's line contain iron. Fine. Now there are also more lines which are present in various corneal pathologies. They also contain iron. Now you have to tell me where does these lines form. Hudson-Starley line, Ferry's line, can anyone just tell me where does these lines form? Hudson-Starley line, it is a kind of a physiological due to iron present in the tear film. Okay, it is present in the interpalpebral part. Okay, physiological iron present in the tear film. This is seen in bleb, which we make in trabeculectomy. Trabeculectomy, it is a procedure which we use in glaucoma patients. That is not a part of this discussion, but just you can just remember Ferry's line can be formed in bleb. Okay, which we made in trabeculectomy. Okay. Now as pterygium can vary in size, it can be a small pterygium, it can be a large pterygium, but there are some indications for pterygium treatment. Please tell me the indications of treatment for pterygium. Yes, Shivam, Krish, Adyut, Tanya, Please tell me the indications of treatment. If it is decreased vision, cosmetic problem, present on visual axis. If patient is having these problems, only when we'll think of treating the pterygium. If the pterygium is very small, not causing any problem to the patient, we'll generally not treat it. Okay, we'll generally not treat it. Yes, Adyut and Krish, you are right. Okay. Now, treatment modalities in pterygium. Blair-Sclera technique, Bayer-Sclera technique, and perfect surgery. Now you people have to tell me the full form of perfect surgery. Okay, you have to tell me what is squint. Squint generally don't occur in pterygium. Squint, if at all, occurs in a very late stage. Squint doesn't occur in pterygium. No, Krish, no. Bayer-Sclera technique is, I just want to tell you, in Bayer-Sclera technique, what will we do is, in Bayer-Sclera technique, just hold on. In Bayer-Sclera technique, we'll remove this part of the conjunctiva and we'll leave it as such. So the sclera underlying this conjunctiva will be bare. So this is known as Bayer-Sclera technique. Not practiced now, but you should know it. Okay, it is Bayer-Sclera technique. Anyone? Full form of perfect surgery? I need the full form. Krish, tell me the full form. It is pterygium extended removal followed by extended conjunctival transplantation. This is the full form of perfect. Yes, resection will do. Cornea transplant करेंगे तो resection तो करेंगे conjunctiva का. Now I just want to tell you briefly what we'll do in perfect surgery. In perfect surgery, we'll take this part of the conjunctiva on the superior side. Superior bulbar conjunctiva will harvest some conjunctiva from here, exactly more around this size of the lesion. Will harvest this conjunctiva and will remove this conjunctiva. This part of the conjunctiva will remove. Disease part will remove. This disease part will remove, and the conjunctiva that we have harvested from here will place here. Okay, will place here. So this is known as pterygium extended removal followed by extended conjunctival transplantation. Okay, so now you people must have understood what is meant by the perfect surgery. Okay, so that is all for the conjunctiva. Now we'll discuss cornea. Okay, now we'll discuss the cornea. Okay, the difference between these two surgeries. In Bayer-Sclera technique, we'll just remove the sclera and will not put conjunctiva over it. Okay, so that is why this technique is known as Bayer-Sclera technique. Bayer-Sclera will remove the conjunctiva and will not put the conjunctiva over it, and the sclera will lie bare. But in perfect surgery, we'll remove the conjunctiva and we'll harvest a piece of conjunctiva from the superior bulbar conjunctiva and will place over it, and we'll place that harvested conjunctiva over this part. So the sclera will not lie bare. It will be covered by the new harvested conjunctiva. Okay, fine. So that is all for the conjunctiva. Now we'll discuss the cornea. Okay, now we'll discuss the cornea. Now we'll discuss the cornea. Okay, Just 1 minute. So cornea, as you all know, it is the outer layer of the eyeball. Okay, it is the outer layer of the eyeball. So first, coming on to the anatomy of the cornea. Anatomy of the cornea. Now you people have to tell me not 5 but 6 layers of the conjunctiva. Okay, 6 layers of the conjunctiva. Yes, Devansh, please tell me 6 layers of cornea. Sorry, cornea. 6 layers of cornea. Okay, tell me 6 layers of cornea, starting from outside to inner side. Okay, starting from outside to inner side. First one is the epithelium. Second is the Bowman's layer. Bowman's layer. Third one is stroma. Stromal layer. Fourth one is Dua's layer. This has been newly discovered. Dua's layer. Descemet's membrane and endothelium. Now you have to tell me the type of epithelium which is present over the cornea. Type of epithelium. Come on, just tell me the type of epithelium which is present over the cornea. It is non-keratinized. Non-keratinized stratified squamous epithelium. Okay, non-keratinized stratified squamous type of epithelium. Okay, it is the outer barrier of the cornea. Okay, now coming on to the Bowman's layer. This is acellular. No cells are present in this layer. Okay, this is, we can say, outermost part of the stroma. Outermost part of stroma. Okay, and it doesn't regenerate after trauma. It doesn't regenerate. If at all cornea is injured, cornea has a pathology, this layer doesn't regenerate after the pathology. Now stromal layer. This is the thickest layer of the cornea. Thickest layer of the cornea. Thickest layer of the cornea. It has keratocytes and core proteins, which are gags and proteoglycans. Can anyone just tell me the gags which are present in cornea, which are present in stroma? Type of gags. Glycosaminoglycans. Just tell me the gags. They are chondroitin sulfate, others you have to tell me. Chondroitin sulfate, heparin sulfate. Okay, not heparin sulfate, chondroitin sulfate and dermatan sulfate. These two are present in the cornea. And proteoglycans. Okay. Fourth layer is a Dua's layer. Which is present between the stroma and the Descemet's membrane. 10 micrometer thick. Okay. Descemet's layer, it acts as the basement membrane for endothelium. Basement membrane of endothelium. It is also around 10 micrometer. Okay. Now endothelium, it has a layer of hexagonal cells. Hexagonal cells are there in the endothelium. Now I just want to know what is the specular count of endothelium at birth and in the adult age group. At birth and in adult age group. Specular count, it is around 6,000 and it is, in adults it is only around 3,000. Okay, so it keeps on decreasing, but cornea is severely compromised if it is less than 500. Okay, if it is less than 500, then the cornea will be severely compromised. Okay, now what is the function of the endothelium? Can anyone just tell me the pump which is present in endothelium? Which pump is present in endothelium? No, Bhuvansri, 3,000 to 4,000 is not at birth. It is 6,000 at birth. Okay, it is 6,000 at birth. It is around 3,000 in the adult age group. Okay, it is around 3,000 in the adult age group. Fine. So I have sodium potassium pump, sodium potassium ATPase pump, which keep on pumping fluid outside the cornea. So it helps to keep the cornea dry and transparent. Fluid, whatever amount of fluid is present in the cornea, endothelium helps. This pump in the endothelium helps to keep the fluid out of the cornea by pumping the fluid out of the cornea in the aqueous humor, in the anterior chamber. Okay, in anterior chamber. So in this diagram here you can see the 5 layers of the cornea. This is epithelium, outermost layer. This is the Bowman's, second most layer. Stroma, third layer. Descemet membrane, it is the 4th layer, and endothelium, this is the 5th layer. Okay, so endothelium, it is the thickest layer. Okay, thickest layer of the cornea, right? Now dimensions of the cornea. Dimensions of the cornea. Okay, horizontal diameter and vertical diameter. Please tell me which diameter is more. Horizontal diameter is longer or vertical diameter? It is horizontal diameter. It is more than the vertical diameter. Okay, horizontal diameter, it is around 11 mm and vertical is around 11, and horizontal it is around 11.75. okay, it is around 11.75. And also radius of curvature of anterior part of the cornea and the posterior part of the cornea. Which is more, anterior or posterior? Just tell me. Yes, Adyut, I will tell you the types of collagen in the cornea. I will tell you. After this, I will tell you the types of collagen also. Anterior radius of curvature is more than the posterior. Okay, anterior radius of curvature is more than that of the posterior one. Okay. Keratometry. What is the average value of the keratometry of the cornea? It is somewhere around 42 to 48. This is the average keratometry of the cornea. Okay. Now types of collagen as requested by Adyut Prakash. Types of collagen. Now just tell me one thing, Adyut, which type of collagen it is present in basement membrane? From pathology you must be knowing what type of collagen is present in the basement membrane. It is type 4, right? Type 4 type of collagen is present in basement membrane. So Descemet membrane and Bowman's membrane, they are both like a basement membranes only. So Descemet membranes and Bowman's, they will have type 4 collagen, and in stroma type 1 collagen. Okay, stroma will have type 1 collagen, Descemet membrane and Bowman membrane will have type 4 collagen. Okay, yes, Nikhil and Bhuvanashri, type 4 collagen, it is present in the basement membrane. So basement membrane, there are two basement membranes in the cornea, Descemet membrane and the Bowman's membrane. Fine. Stroma, it is type 1. Okay, now I think you will not forget this. Okay, now nerve supply of the cornea. Now a little bit anatomy. I want to test your anatomy first. Okay, what is the sensory supply of the cornea? Can anyone just tell me the sensory supply? Fifth cranial nerve. Can anyone just tell me the name? Yes, Nikhil, Bhuvansri, Adyut, please tell me the name of fifth cranial nerve. Yes, it is trigeminal nerve. Okay, trigeminal nerve. Now there are three branches of trigeminal nerve. Yes, Ashwani, you are right, it is trigeminal. Now you have to tell me the branches of trigeminal. Okay, first one is ophthalmic, second one is mandibular, third one is the maxillary. Okay, these three branches are the branches of trigeminal nerve. Now for the sensory nerve supply of the cornea, it is long ciliary nerve. Which is a branch of the ophthalmic nerve. It is the terminal branch of the ophthalmic nerve. It is long ciliary nerve. So this supplies the cornea. Okay. Yes, Ashwani, you are right, ophthalmic, maxillary and mandibular, but the long ciliary nerve, which is a branch of ophthalmic nerve, it supplies the cornea. Okay, it supplies the cornea. Now I have already told you the nerve supply of the cornea. You have to now tell me the causes of enlarged and prominent corneal nerves. See, there is difference between enlarged and prominent. Okay, now you have to tell me the etiologies having enlarged corneal nerves and having the prominent corneal nerves. Just tell me the causes for enlarged corneal nerves. I have one mnemonic for it. It is Relman. Now you have to fill this mnemonic up. Yes, Devansh, you can ask the doubt. What is the doubt? Yes, tell me the doubt. Meanwhile, I will tell you what is Rallman. It is Refsum disease. Yes, nasociliary branch supplies the cornea. Yes. Ophthalmic. Okay, I will tell you in detail. Okay. Just hold on. This ophthalmic branch has another three nerves. Sorry, I forgot to tell you people. Nasociliary, frontal and lacrimal. Now you have to revise with me. Trigeminal has three parts: ophthalmic, mandibular and maxillary. Ophthalmic has further three parts: nasociliary, frontal and lacrimal. Thank you Devansh for reminding me. Now long ciliary nerve, it is a branch of nasociliary nerve. I want to correct myself. Long ciliary nerve, it is a branch of nasociliary nerve, okay, which is in turn a branch of ophthalmic nerve. So this is the hierarchy of the nerves, okay. Fine. Now causes for enlarged corneal nerves. First one is the Refsum disease, Acanthamoeba, leprosy, Men 2A disease, neurofibromatosis, Refsum disease, Acanthamoeba, leprosy, Men 2A disease and neurofibromatosis, okay. Now causes for prominent corneal nerves. Causes for prominent corneal nerves, very common etiology in the cornea. You must have heard of this etiology, Keratoconus. Okay, Keratoconus is the cause for prominent corneal nerves. Other causes, glaucoma. It also leads to enlarged prominent corneal nerves, okay. So now coming on to the factors maintaining the corneal transparency. One factor I have already told you. Now you have to tell me that factor. Tell me that factor. I have already told you. It is sodium potassium pump. Sodium potassium ATPase pump. Okay. Avascularity of the cornea. There is no vascular supply in the cornea, so that also helps to keep the cornea transparent. Okay. IOP. Okay. And epithelium, arrangement of collagen fibrils in stroma, okay. So these all factors helps cornea maintain its transparency, okay. Yes, it is lattice arrangement in the stroma, okay. Lattice arrangement of collagen fibrils in the stroma helps to maintain the corneal transparency, okay. Avascularity, epithelium and sodium potassium ATPase pump, these all factors helps cornea maintaining its transparency, okay. Now the grades of corneal opacity I'll write for you people, and now then you people will tell me the level of each opacity, okay. Nebula, macula and leucoma. Nebula, macula and leucoma. You have to tell me the level of each opacity. Yes, nebula, it is till Bowman's membrane. Macula, it can involve Bowman's and the anterior half of the stroma, and leucoma, it can extend till the posterior stroma, okay. It can extend till the posterior stroma. And fourth one is adherent leucoma. Adherent leucoma, if leucoma occurs in full thickness plus iris incarceration. Leucoma cornea plus iris adhered over the endothelium of the cornea. If that is adhered to the cornea, if iris is adhered to the cornea, then that is known as adherent leucoma. Okay. Fine. Now bacterial keratitis. Predisposing factors for the bacterial keratitis, you people have to tell me. Keratitis definition, I think I don't need to tell that. Keratitis is inflammation. So inflammation of the cornea, bacterial cause. Okay. Mainly corneal ulcer can occur. Okay. Corneal ulcer can occur. Predisposing factors for bacterial keratitis: contact lens use, trauma, any underlying ophthalmic condition, okay, like dry eye or anything, okay, or endophthalmitis. All these conditions can lead to bacterial keratitis. Okay, there are various causes of bacterial keratitis like staph, strepto. There are some bacteria usually cannot penetrate the intact cornea, but there are some bacteria which can penetrate the intact cornea. Now you people will tell me the bacteria which can penetrate the intact cornea. Vidyut, Devesh, Bhuvansri, Krish, please tell me the bacteria which can penetrate the intact cornea. Fast. It is Haemophilus, Corynebacterium, Listeria, Shigella, okay, and Gonococcus, Meningococcus. These can penetrate the intact cornea, okay. Neisseria, gonorrhea, and Neisseria meningitis, okay. Pseudomonas, it is not Pseudomonas. Adyut, Pseudomonas cannot penetrate the intact cornea. Yes, I have already told you Shigella, Haemophilus, Corynebacterium, Listeria, Shigella, Gonococcus and Meningococcus. These all bacteria can penetrate the intact cornea, okay. Now clinical features. Now you have to tell me the clinical features of ulcer. Clinical features of an ulcer. How does ulcer present to us? How does an ulcer present to us? That discharge, lacrimation, redness, chemosis, that all I know. I want to know the other features of the ulcer, okay. It is epithelial defect. Epithelium of the cornea will have a defect, like for example this is a cornea, so depending upon the etiology and depending upon the extent, for example this part of the epithelium may be missing or this part of the epithelium may be missing, so this is known as epithelial defect. Along with the epithelial defect, it can have infiltrates, it can have keratic precipitates over the endothelium, okay. So these are all the features of epithelial defect: infiltrates, keratic precipitates, lacrimation, discharge, redness, chemosis. All these are the features of bacterial keratitis, okay. Now investigations that can be done in a patient of corneal ulcer. Investigations, what investigations do we do in patient of bacterial keratitis? Come on people, tell me fast. It is scraping. We'll take the needle, for example this is the ulcer, okay. For example this is the ulcer, we'll scrape the ulcer, okay. We'll scrape like this we'll scrape the ulcer with a needle like this, okay, not too deep, otherwise it will perforate the cornea. We'll scrape cornea like this. So for from what area do we scrape? We scrape the ulcer near its margin and base, okay, and then the scraped material is sent for gram staining and KOH staining, okay. Now I will test your microbiology here. Now you will tell me the steps of gram staining. Steps of gram staining, you people must be knowing better than me. You people have to tell me the steps of gram staining. After scraping, we'll do gram staining of that scrape and we'll do KOH staining, okay, to know the etiology, whether it is fungal or it is bacterial, okay. So for gram staining, what is the procedure? Yes, Adyut, culture also will do. I am coming on it. First scraping, okay, scraping. For scraping, we can do gram staining and KOH staining. Now steps of gram staining. Come on, you have to tell me now. It is just a second. Crystal violet. First we'll put crystal violet, okay, then we'll put iodine, then we'll put acetone as a decolorizer, then we'll put acetone, and then we'll put safranin, So these are all the steps of gram staining. And KOH, 10% KOH, we can see hyphae if fungus is the etiology. If fungus is the etiology, we can see hyphae in the KOH staining. And after scraping, we can also go for culture. Now culture medium used for bacterial keratitis. Now tell me the Adyut, you have to tell me the culture medium now. Just tell me the culture. What type of agars we'll use? It is blood agar and chocolate agar. Mainly these are used for the bacterial etiology, okay. Now after doing the investigations, we can know what is the cause for the bacterial keratitis. Now coming on to the treatment. Lubricants नहीं देने इसमें. It will dilute the antibiotics that you will give, na. Lubricants, until and unless there is very much irritation, lubricants नहीं देने इसमें, okay. We will not give lubricants. We'll give antibiotics, okay. Antibiotics. Broad spectrum antibiotics will start. We'll start with quinolones, moxifloxacin, okay. We can give cephalosporins like ceftriaxone. We can give aminoglycosides like gentamicin. We can give cycloplegics to relieve the ciliary spasm. Okay. And steroids are also contraindicated in bacterial keratitis. Not contraindicated, I will say. They are not given initially, but they can be given after 24 to 48 hours of starting of the antibiotic. Okay, we will not give them immediately, okay. So mainly treatment is antibiotics and cycloplegics. These two constitutes the main treatment for bacterial keratitis, okay. Now fungal keratitis, you have to tell me the predisposing factors for fungal keratitis. Now come on people, tell me. Vegetative trauma, yes. Vegetative matter trauma, okay, like mostly occurs in farmers. Farmers are more predisposed for vegetative trauma, and that trauma, any other trauma can also cause fungal keratitis. Immunocompromised patients, like diabetes mellitus, they are also more predisposed to fungal keratitis. Okay, they are also, yes Adyut, you are right, organic matter trauma, or we can say vegetative matter trauma, these both are same. Okay, now diabetes mellitus, any other immunocompromised condition like cancer, so any condition in which immunocompromised status is immune status is compromised, that can have fungal keratitis. Okay, now causative agents for fungal keratitis, you have to tell me the causative agents for the fungal keratitis, right? These can be filamentous, this can be non-filamentous. Okay, now I'll test your micro here. What are the types of non-filamentous fungus? Okay Adyut, you are asking ki if bacterial ulcer is not cured even after giving the fortified antibiotics, then what will we do? Okay, we can stop all the antibiotics that we are giving, we can stop all the antibiotics, and we can take the culture, we can again take the culture of the ulcer. Okay, and then we'll do the culture, and the bacteria, whichever bacteria will come in the culture, will start that specific antibiotic for that bacteria. Okay, we'll stop the empirical antibiotics and then we'll give the specific antibiotics. This we can do for the ulcer which are not cured even after giving the fortified antibiotics, and we have to look for any other cause that we have that might we have missed earlier. So thorough examination, we have to stop all the antibiotics and then we have to do the culture or scraping again. Okay, stop all the antibiotics for 24 hours and then do culture and scraping again, and then start the antibiotics according to the report of the culture. Okay, now coming on to the filamentous and non-filamentous causes of fungal keratitis. Now first tell me what is non-filamentous fungi. What are the examples of non-filamentous fungi? Yes Devansh, you are right, most common is filamentous, that is aspergillus. I am coming on it, but first you have to tell me the non-filamentous, that is yeast and candida. Come on yaar, you people are studying microbiology also, so you have to tell me along ophthalmology the microbiology also. Okay, now for the filamentous, they are again of two types, septate and non-septate. Okay, non-septate, it is mucor and rhizopus, and septate, they are aspergillus and fusarium. So these are septate fungi, these are non-septate fungi, and these are non-filamentous fungi. So you have to remember these causes. Out of these causes, aspergillus is the most common cause for fungal keratitis. Okay, aspergillus is the most common cause for fungal keratitis, right? Now you have to tell me the clinical features of fungal keratitis. Clinical features of fungal keratitis. There is mnemonic for it. I'll tell you the mnemonic. It is dry fish. Dry fish. It is dry looking ulcer. That epithelial defect, infiltrates, capes, discharge, redness, that all will be present in every keratitis. I am not repeating it again. I am just telling you the salient features which will be present only in the fungal keratitis, right? So dry looking ulcer, feathery margins, that margins will not be sharply delineated, they will be fuzzy. So that is why feathery margins. Immune ring of Wesley will be present. Immune ring of Wesley will be present. Okay, satellite lesions. Satellite lesions. Are you people there? You are not writing your answers in the chat box. Please participate with me. Okay, you cannot sit like this, you have to tell me the answers also. Okay, satellite lesions. So these are the salient features which helps us to differentiate from the other kind of ulcers. Okay, ulcer will be dry looking, it will be feathery, it will have immune ring of Wesley, and it will have a satellite lesions. So what does it mean by satellite lesions? So for example, this is the cornea. So some of the lesions will be here, some of the lesions will be here, some of the lesions will be here. So these are known as the satellite lesions. Okay. Yes, hypopion will be also be present, but it can also be present in fungal, in bacterial also. So this is not a salient feature for fungal keratitis. Okay. So now as you have told me fungal hypopion, yes, Adyut, you are right. Right, symptoms less than signs. Signs I have already told you. Dry fish. Now hypopion, Devansh, as you have written hypopion, now you have to tell me कि फंगल का हाइपोपियन फिक्स होगा या मोबाइल होगा, या बैक्टीरियल का फिक्स होगा या मोबाइल होगा. हाइपोपियन, इफ द पेशेंट विल लाई डाउन, which we can see which will remain fixed and which will keep on moving. Fungal will have fixed hypopion. Okay, even if the patient lies, the hypopion will remain as such. Okay, but in bacteria it is mobile. It is mobile in bacteria. So F for fungal, F for fixed. Okay, hypopion. Yes, you are right, Devansh, and immobile hypopion, or we can say fixed hypopion. Okay, yes, fixed is fungal. Okay, bacterial is mobile, right? Now the investigations. Scraping I have already told you, people. Scraping I have already told you. Culture. Now you have to tell me the culture. किसमें करते हैं फंगल केराटिटिस का कल्चर? Sabor dextrose agar. Okay, scraping we can do in 10% KOH. 10% KOH. Other investigations that can be used in fungal keratitis. Now you have to tell me the name of other investigations. Okay. It is Giemsa staining, calcofluor white stain. Come on, people, this is microbiology. You have to tell me at least the name. I'm not asking the procedure, I'm not asking the stain, I'm just asking the name of the investigations. Okay, it is Giemsa staining, calcofluor white stain, acridine orange. Okay, these are all are the other stains which we can use in fungal keratitis. Okay, now treatment you have to tell me now. See, along with ophthalmology, you must also know the ocular pharmacology, ocular pathology, ocular microbiology also. Okay, only ophthalmology is not enough. You have to know the related pharmacology also, microbiology also, pathology also, and related community medicine also. Okay, so ophthalmology is not just one subject. You have to know the related things to ophthalmology also. Okay, so treatment, lubricants will not give, antifungals will give. Yes, natamycin and amphotericin. Now Adyut, you have to tell me amphotericin is used for what and natamycin is used for what. Okay, natamycin, I agree, it is natamycin, antifungals, natamycin. It is for filamentous fungi. It is for filamentous fungi. And amphotericin, it is for yeast and candida. Okay. Steroids are strict no. Steroids are strict no. If you give steroids in fungal, na, it will get flared up. Steroids no. I am writing in red. Okay. Steroids are strict no. Okay. Antifungals, cycloplegics we can give. If not getting resolved, these are the oral eye drops. Topical eye drops. If not resolved, we can give oral antifungals also. Okay, oral antifungals also if the keratitis is not getting resolved. Yes, you are right, Devansh. Amphotericin B for candida, and natamycin for filamentous fungi, right? Now the viral keratitis. Now you first have to tell me the causes for viral keratitis and then the predisposing factors. Now you have to tell me the main two causes of, they can be many causes of viral keratitis, but there are main two causes of viral keratitis. Two causes: herpes simplex virus and herpes zoster virus. Okay, these are the main two causes of viral keratitis. Okay, there can be any other also, but here now we'll discuss only these two, herpes simplex and herpes zoster. Okay, now predisposing conditions: immunocompromised. Okay, immunocompromised. Okay, if the patient have suppose if the patient have history of viral infection in the childhood, so these viral infection can again get reactivated due to some predisposing conditions like fever, trauma. Okay, so they can get reactivated and then they can cause the viral keratitis. Okay, so patient may have history of viral disease in childhood. Okay, and one cause I have already told you in the conjunctival part, that is during birth. HSV2 is the cause of keratitis if there is infective birth canal. Okay, HSV1 is the cause for above the waist kind of the lesions, and HSV2 is below the waist. Okay, this you must be knowing. Okay, so immunocompromised, history of viral disease in the childhood. Okay, these are the main two causes for viral keratitis. Causative agents I have already told you, HSV and herpes zoster virus. Okay, now we'll discuss one by one HSV and herpes zoster. Okay, primary and secondary infection that I've already told you. Primary infection, if there is a history of viral infection in the childhood, patient can again have the lesion in the adults. As this virus, it lies dormant in the ganglion. Which ganglion? Which ganglion is related with the eye? I have already told you this thing. Now you have to answer it. It is trigeminal ganglion. Okay, virus can lie dormant in the trigeminal ganglion and it can again get reactivated. Okay, due to some stressful condition. Okay, now coming on to the HSV keratitis. Now there are three components of HSV keratitis. We'll discuss it under three components. Okay, epithelial, stromal and endothelial. We'll discuss the presentation of viral keratitis under three headings: epithelial, stromal and endothelial. Okay, fine. So in epithelial keratitis, in epithelial type of keratitis, we'll have dendrites. Okay, mainly dendrites will be present. Dendrites will be present. They will have branching and they will have bulbs at their ends. So this is a characteristic feature of the dendrites which is present in the herpes simplex virus keratitis. And then discharge, lacrimation, redness, this all will be present. Okay, now the stromal keratitis, we'll discuss it under two headings: immune mediated and necrotizing. ठीक है, it is due to antigen antibody complex. Okay, in this there will be no epithelial defect. In this epithelial defect will be present. Okay, in epithelial type, epithelial defect can be present along with the dendrites, fine. And in stromal, if it is immune mediated, it will have deposition of antigen antibody complex with no epithelial defect. And in necrotizing type of stromal HSV keratitis, epithelial defect will be present along with the stromal opacities. Okay, endothelial type, it is also known as disciform keratitis. It will have endothelitis. It will have endothelitis also, and it will have endothelitis and capies. So it is known as disciform type of endothelial keratitis. Okay, disciform type of endothelial keratitis, right? HSV clinical features we have discussed. Now coming on to the HZO, herpes zoster ophthalmicus. Herpes zoster ophthalmicus. Now there are shingles present. Shingles present in herpes zoster. Skin lesions, these are skin lesions present on tip of nose, on the side of eye involvement. For example, if the right eye is involved, then right side of the tip of the nose will be involved, and right side of the nose will have the skin lesions. Okay, so there is one rule which governs these lesions. Can anyone tell me the rule? What is the name of that rule? It is Hutchinson's rule. Okay, it is Hutchinson's rule. Now you have to tell me the nerve which is involved in Hutchinson's rule. Yes, Hutchinson's sign or Hutchinson's rule, you can say that. I have already told you the name of that nerve. Okay, now you have to tell me the name of that nerve which governs the Hutchinson's rule. Come on people, now you have to tell me. Okay, please tell me the name of that nerve. No one? Bhuvanasri, Adyut Prakash, Chitti, please tell me the name of that nerve. That is nasociliary nerve. इसके नाम में हचिनसन रूल लिखा है. Nasal involvement and ciliary involvement in the eye. Nasal involvement in the nose and ciliary involvement in the eye. So this nerve is responsible for the Hutchinson's rule. Now more characteristic, there is one branch of nasociliary nerve which governs that rule. Nasociliary nerve is okay. Broad category is nasociliary nerve, which is a branch of ophthalmic nerve, which in turn is a branch of trigeminal nerve. But nasociliary nerve की भी आगे एक branch है which is responsible for the Hutchinson's rule. Can anyone tell me the name? It is external nasal nerve. External nasal nerve. This is the nerve which is responsible for the Hutchinson's rule. Okay. Now corneal clinical features, almost same as that of the HSV. It can be epithelial, stromal and endothelial. Epithelial is also known as nummular type. Why it is known as nummular, I will tell you. Now dendrites are also present in HZO, but these are different from that as that of HSV. Now can anyone tell me the difference in dendrites which are present in herpes zoster? Yes, Bhuvansri, external branch, I have already told. Now you have to tell me the difference in the dendrites of HZO. Okay, so they will not have terminal ends. Terminal bulbs will not be there in herpes zoster. Okay, and in nummular, if along with epithelial involvement there is stromal haze, okay, that is known as nebular keratitis. Okay, stromal haze is present along with the epithelial involvement, then that is known as nebular keratitis. Endothelitis, I have already told you that disciform type. Okay, disciform type. Okay, now corneal clinical features, I have already told you. It is epithelial, stromal or endothelial. Other ocular features, apart from cornea, herpes zoster can also involve the other structures of the eye. Can anyone just tell me? Yes, Adyut, they are also known as pseudodendrites because they have no terminal end. Yes, you are right. Okay. Now you have to tell me the other ocular clinical features of herpes zoster. Patient can have conjunctivitis, episcleritis, okay, retinitis, ठीक है, optic nerve lesions. So it can affect any part of the eye, okay, not just cornea, it can affect any other part of the eye. Right? Now coming on to the investigations. Okay, coming on to the investigations. Giemsa staining we can do. Okay, and one most oftenly heard investigations in the last 2 years, you have to tell me this now. Okay, you have to tell me this now. Why are you writing third nerve palsy, Devansh? What does it mean here? Giemsa staining and PCR, okay, and nucleic acid amplification test. Okay, PCR, RT-PCR सुना है ना कोविड में. It is reverse transcriptase for RNA virus, but herpes is DNA. Okay, so only PCR. Okay, कोविड में हम RT-PCR कराते थे क्योंकि वो RNA के लिए था. Herpes is DNA, so we'll only go with PCR. Okay, nucleic acid amplification test. Fine. Treatment, I'll separately tell you the treatment for stromal, epithelial and endothelium. Okay, epithelial में we'll give antivirals. Now you have to tell me the name of, yes, it, nerve palsy is very rare with it's HZV, very rare with HZV, third nerve palsy. Third nerve palsy के और बहुत से causes हैं, ठीक है, I'm not going into those causes, but HZV can be a cause but not very common cause. Okay, now antiviral, you have to tell me the antiviral. It is acyclovir. Okay, others can be ganciclovir. Okay, steroids will not give in epithelial type. Steroids are strict no. Epithelial defect, if at all there is epithelial defect na, steroids are highly contraindicated. Okay, so epithelial involvement में steroid नहीं देना. Okay, now stromal, if there is no epithelial involvement, only stromal, then we'll give topical steroids. Okay, stromal में we can give steroids, steroid eye drops. Antiviral we can give along with it. So these both are the treatment for stromal and endothelial, steroids and antiviral. Antibiotic generally not given until and unless the ulcer is very severe. Antibiotics are not given in viral keratitis. Okay, we can give if there are added super infections, but not generally we don't give antibiotics in viral keratitis. Okay, yes, steroid in disciform and endothelial I have already told you. ठीक है, but not in epithelial type. Okay, steroids are contraindicated in epithelial type of keratitis. Okay, now neurotrophic keratitis. Neurotrophic keratitis में there is no causative agent, I will say. Causative agent नहीं होता कोई neurotrophic में ना, तो why there is a keratitis? अगर कोई causative agent नहीं है, no bacteria, no fungal, no viral, then why does neurotrophic keratitis occur? Can anyone tell me? Why does neurotrophic keratitis occur if there is no causative agents? It is failure of reepithelialization. Failure of reepithelialization due to decreased corneal sensation. After viral keratitis, corneal sensation can decrease. Okay, so viral etiology we can treat with antivirals, but due to the damage to the cornea by virus, corneal sensations can be decreased. So if the corneal sensations are decreased, failure of reepithelialization can occur. Even a small epithelial defect in the cornea cannot heal properly. Okay, if there is small epithelial defect in the cornea, it cannot heal properly. So failure of reepithelialization is there in neurotrophic keratitis. Okay, now what is the treatment? I just want to tell you that we have to protect the epithelium. We have to protect the epithelium. So what we can do? We can give lubricants for epithelium to heal, preservative free lubricants. Okay, what else we can do? What else we can do? You have to tell me. Neurotrophic keratitis is a part of keratitis only. You have to tell me the treatment. Lubricants we can give. What else? We can put AMG over the defect. We can do tarsorrhaphy, that is partial closure. We can partially oppose the two eyelids so that there can be less exposure of the diseased epithelium to the external environment. Tarsorrhaphy we can do. Okay, so it is temporary tarsorrhaphy. Okay, we can put bandage contact lens also. Okay, and one thing I want to tell you that epithelium is not stained by any dye in neurotrophic keratitis because there is no causative agent present. Okay, no staining, neither with fluorescein nor with rose bengal. Okay, not stained with any kind of staining. Okay, now Acanthamoeba keratitis. Okay, now you have to tell me the predisposing factors for Acanthamoeba. Tell me the predisposing, most common, most characteristic factor for Acanthamoeba keratitis. Tell me now. It is contact lens. Okay, contact lens related keratitis, if at all it is there, most characteristic cause for a contact lens is Acanthamoeba. Okay, Acanthamoeba. Okay, other causes can also be there, but contact lens is the most common cause. Okay, brackish water, exposure to brackish water. Okay, sea water. ठीक है, कॉन्टैक्ट लेंस से कैसे होगा? इफ द solution is contaminated solution, use of contaminated solution in contact lens can lead to Acanthamoeba keratitis. Okay, clinical features, that pain, that redness, discharge, discharge, lacrimation, that all will be present. You have to tell me the characteristic features. Features. Yes, pond bath. Yes, seawater, pond bath. These all can lead to Acanthamoeba keratitis. You have to tell me the characteristic features of Acanthamoeba. Okay. Most common characteristic feature will be pain. Pain will be very much. Okay. It is due to the radial keratoneuritis. Nerve will be severely infected, that is radial neurokeratitis. Pain will be very much. बाकी के keratitis में pain होगा but not to that much extent as that it will be present in Acanthamoeba. Okay. Ring shape abscess, or we can say ring ulcer. ठीक है. Dendrites also can be present. Pseudodendrites can also be there in Acanthamoeba. But pain, remember, is the most common feature. Ring shape abscess. Okay, ring ulcer we can say. These are the most common feature for Acanthamoeba keratitis. Okay. Now investigations. Okay. Acanthamoeba के there are two parts, cyst and trophozoite. Cyst is a dormant part. Trophozoite is the infective part. Okay. So main infection, it is due to the trophozoite, not due to the cyst. It is a dormant part. Okay. Now investigation, that Giemsa stain and acridine orange, all these can be used for Acanthamoeba keratitis. And culture, one specific culture only for Acanthamoeba. Can anyone tell me that name of that culture? Yes, Adyut, you are right, very much right. Non-nutrient agar with E. coli. Very good. It is non-nutrient agar with E. coli. Okay. Treatment is ABC. Okay, cycloplegics, so we'll give. Okay, but ABC is the mnemonic. A is for aminoglycoside, B is for biguanides. Biguanides, it is PHMB. Chlorhexidine, and propamide. Okay, these are all can be used in Acanthamoeba keratitis. Okay, fine. Now Microsporidium keratitis. So causative agent is Microsporidium only. This is evident from its name. Okay, Microsporidium is a type of fungi. Okay, mainly it is a intracellular pathogen, not free living, intracellular pathogen. Okay. Predisposing factor, immunocompromised status, most common cause. Immunocompromised status is the most common cause for Microsporidium keratitis. ठीक है. Clinical features, if the patient is immunocompromised, the patient will have conjunctivitis. If immunocompetent, they can have stromal involvement. Okay. Investigations already discussed previously also, but I'll repeat those again. Giemsa staining, acridine orange, calcofluor white, all these can be used. Confocal microscopy, okay, these all can be used in Microsporidium keratitis. Now coming on to the treatment of Microsporidium, it is albendazole, fumagillin, and cryotherapy. Main treatment for Microsporidium keratitis. Okay. Now keratoconus, it is the most important topic in the cornea, most frequently asked in the examination, so you people have to participate in the discussion of keratoconus. Okay. Now the definition of keratoconus. It is protrusion of the cornea associated with corneal thinning. Okay, for example, this is a cornea. Okay, but in keratoconus it will be abnormally protruded and will be thin in the center as compared to the periphery. So this part will be very thin. Okay, so protrusion of the cornea associated with corneal thinning. There are various risk factors for keratoconus. Okay, family history is important. Associated history of VKC, अगर VKC पहले हो रखा है then keratoconus can occur in future. VKC में there is eye rubbing due to irritation. Okay, so can lead to keratoconus. Okay, other associations of keratoconus, systemic associations of keratoconus. Adyut, yes, you are right. Increase in corneal curvature, very much right. Now you have to tell me the associations of keratoconus. There is mnemonic for it. It is flamed. Okay. Floppy lid syndrome. Leber's congenital amaurosis. Atopic disease. I have already told you VKC. Atopic disease, history of atopic disease, mitral valve prolapse, Marfan's disease, all these are associated with keratoconus. Okay, connective tissue disorder, in this they can be Ehlers-Danlos or osteogenesis imperfecta. Okay, D is Down syndrome. So all these conditions can lead to keratoconus. Okay, now apart from eye, what are the clinical features? Patient will come you with the complaint of rapid change of glasses. Okay, due to induced astigmatism, due to corneal thinning and protrusion, they induce astigmatism, by which patient will complain of decreased vision and there will be frequent change of glasses. Okay, eye rubbing, already told you. Okay, other associated conditions of the eye which can occur in keratoconus, tell me now. Not related to the cornea but any other conditions involving other parts of the eye. There can be retinitis pigmentosa. Okay, Leber's congenital amaurosis. Okay, these two can also occur along with the keratoconus. Fine. Now I have forgotten you to tell you the signs of keratoconus. Okay, now we'll discuss here only. So in this pictures you can see corneal thinning. Corneal thinning is there. In this picture you can see Vogt striae. Vogt striae breaks in Descemet membrane. Due to excessive stretching due to protrusion, there occurs break in the Descemet membrane. Breaks in the Descemet membrane. Okay, this is a Munson sign. Munson sign. Okay, Munson sign. This is oil droplet reflex on retinoscopy. Oil droplet reflex on retinoscopy. When we'll do retinoscopy in keratoconus, this kind of reflex will be seen on retinoscopy. Okay, fissure ring. Fissure ring present on the base of the cone. Base of the cone. This is the iron ring. This is the iron. This ring has iron in it, like Stocker's line and Hudson-Starley line and Ferry's line. This ring also has iron in it. Fissure ring. Okay. Now Vogt striae. These are vertical striae. Okay. V for Vogt, V for vertical. Now can anyone just tell me other striae which we encounter in ophthalmology? I'll give you one clue that is related to the glaucoma. Now you have to tell me the name of those striae. Can anyone just tell me the name of those striae which we can find in glaucoma? Anyone? Adut, Life of a Medico. Devansh, please tell me the name of those striae which are found in glaucoma. Yes, very good Adut, these are Hab striae. Okay. How can we differentiate between Vogt striae and Hab striae? V is Vogt, V for vertical, H is Hab and H for horizontal. Okay, this is the main difference between the Vogt striae and the Hab striae. Okay. Now investigations. For investigations we can do refraction. In refraction we can see the astigmatism is there. Okay, and keratometry. Keratometry will be increased. Normal range I have told you in the anatomy of the cornea, it is around 40 to 46 diopters, but in keratoconus it is very much increased, maybe till 55 or 53, like that. Okay. How can we do the keratometry? We can do it using placidodisc examination, OBSCAN, pentacam. These are all the investigations for keratometry. Okay, and we can measure corneal thickness also, that is central corneal thickness, that is CCT. It will be decreased in cornea. Okay, it will be decreased in cornea as there is thinning in the cornea. Okay, so these are the investigations: diffraction, keratometry and corneal thickness, main investigations in keratoconus, right? Now coming on to the treatment for keratoconus. Okay, for treatment we can do complete refraction of the patient. If the patient is not getting any benefit out of the spectacles, we can switch the patient to contact lens use. Okay. Other things, can anyone tell me what are the other treatment modalities for keratoconus? Anyone? Other treatment modalities for keratoconus? Yes, please. Other treatment modalities for keratoconus. Hurry up fast. No one. It is C3R. Have you people heard of this? corneal collagen cross-linking using riboflavin. In this, riboflavin is put over the cornea along with the UV radiation, and it helps to strengthen the cornea, because due to excessive protrusion and due to excessive thinning, cornea becomes very weak. Okay, so our aim is to strengthen the cornea. Yes, Devansh, keratoplasty we can also do, but that usually we'll do in the end stages. Before keratoplasty, we can give the patient contact lens, soft contact lens or rigid permeable glass lens, that is RGPs. Okay, C3R, yes, very good Devansh, C3R, corneal collagen cross linking using riboflavin, okay, to strengthen the cornea, okay, to increase the covalent bonds in the collagen fibrils. Okay, it strengthens the cornea. Okay, the last one is the keratoplasty. In end stages we can do keratoplasty. Okay, keratoplasty I will discuss in the further slides, but for now here you just remember the keratoplasty. Okay, Adut, yes, UVA, not vitamin A, not vitamin A, it is vitamin B. Riboflavin is vitamin B. Okay, not A, it is vitamin B. Yes, Intex, we can also use Intex. These are intracorneal ring segments. Okay, these, for example, this is the cornea. Okay, these rings are placed in the stroma like this. These are 150-degree rings. Okay, these are placed like this in the cornea, in the stromal part. Okay, not by mistake. Okay, vitamin A. Okay, vitamin B is there. Okay, right, fine. Treatment of keratoconus I have already explained you. Okay, I have already explained you the treatment. Contact lens, just repeating, contact lens, Intex, ICRS, intracorneal ring segments, keratoplasty, C3R and spectacles. Main treatment for keratoconus, right? Now, what are the differential diagnosis for keratoconus? First, you tell me the name and then I'll explain you how these conditions are different from keratoconus. Just tell me the name of those conditions which act as a differential diagnosis for keratoconus. Come on, Adyut, Devansh, please tell me the conditions. Life of a medico, please tell me. Bhuvansari, please tell me the name of those conditions. Yes, anyone? No idea. It is pellucid marginal degeneration. Okay, and this is keratoglobus. It is keratoglobus. Okay, now one thing I just want to tell you here, I have not mentioned it before. The keratoconus thinning is most prominent in the inferior part of the cornea. Okay, most prominent in the inferior part of the cornea, in the paracentral region. Okay, paracentral region. Okay, but in pellucid marginal degeneration, thinning is present like a band in the inferior conjunctiva. For example, this is the conjunctiva, this is the cornea. Okay, so from 4 to 8 o'clock position, thinning will be present from 4 to 8 o'clock position like a thinning band. Okay, and corneal protrusion will be above this band. Okay, in keratoconus, in thinning will be present only in the inferior central part, paracentral part. Okay, like this, like here. But in pellucid marginal degeneration, there will be whole band of corneal thinning from 4 to 8 o'clock position. Okay, this is also bilateral. Keratoconus is also bilateral. Okay, and it also occurs in young age group. It also occurs in young age group. It is also there in young age group, but striae and that fissure ring, scarring, they do not occur in pellucid marginal degeneration. Thinning is there, but no striae, no fissure ring, no scarring. These features are not present in PMD. These features are not present in PMD, but these features are present in keratoconus. Okay, these features are present in keratoconus. And keratoglobus, जो thinning है ना, this is present in 360 degree. Thinning is present in 360 degree in keratoglobus, and it usually occurs at birth. Birth पे होता है, and thinning is 360 degree, and striae, scarring, ring, this is also not present in keratoglobus. Okay, this is also not present in keratoglobus. Fine. Okay. Now, cloudy cornea at birth. You have to tell me the causes of cloudy cornea at birth. There is one mnemonic for it, for cloudy cornea at birth. You people have to tell me that mnemonic, and then you have to explain that mnemonic also. Can anyone just tell me the mnemonic? Anyone? Come on, people. Come on, guys. Just tell me the mnemonic at least. I will explain it. No one. It is stumped. Okay. So, stumped. Can anyone just tell me the full form of stumped? Anyone? Okay. T stands for trauma. U stands for ulcer. Sorry, S stands for sclerocornea. I forgot. Sclerocornea. T for trauma, traumatic causes, ulcer. M for metabolic causes, that is mucopolysaccharidosis. Okay. P for posterior corneal defect, posterior keratoconus also we can say, or posterior corneal defect. Endothelial causes, and dermoids. Now, sclerocornea, trauma, any trauma which can occur during birth or during delivery, like forceps delivery, they can cause trauma to the eye, and if trauma occurs to the cornea, it can lead to cloudy cornea at birth. Ulcer, I have already told you people many times, bacterial ulcer, fungal, okay, like in Ophthalmia neonatorum, okay, in viral. Metabolic is mucopolysaccharidosis, okay. Posterior keratoconus can also be the cause. Endothelial causes, now you have to tell me what are the endothelial causes for cloudy cornea at birth. Adyut, Devansh, please tell me now the endothelial causes for cloudy cornea at birth. Just tell me. These are Fuchs endothelial dystrophy, CHED, congenital hereditary endothelial dystrophy, PPCDs, posterior polymorphous corneal dystrophy, thin endothelium. Yes, endothelium thin हो जाएगा इन सब disease में, but I want the disease entities, okay. So these are the disease entities, like Fuchs endothelium, Fuchs endothelial, Fuchs dystrophy, CHED, congenital hereditary endothelial disease, and PPCD, posterior polymorphous endothelial dystrophy, okay. Dermoids, limbal dermoids can be there, which can cause cloudy cornea at birth. Fine. Now peripheral ulcerative keratitis. Okay, peripheral ulcerative keratitis. So in this there will be peripheral epithelial defect and thinning. Epithelial defect will be there, thinning will be there, and epithelial defect, thinning and corneal opacity will be present at the periphery of the conjunctiva. Okay, periphery. Cause can be autoimmune. I'll tell you the causes, but here you can just see, for example, this is the cornea. So ulcer, basically they are usually present here, they can be present here, but peripheral ulcerative keratitis, it is usually present here in the extreme periphery of the cornea, near the limbus. Okay, so this is the site for peripheral ulcerative keratitis, that is why its name. Now causative agents, there are many causes for peripheral ulcerative keratitis, but the main cause is autoimmune disease. Autoimmune disease, these are the main causes for peripheral ulcerative keratitis. Okay, rheumatoid arthritis, Wegener's disease, and PAN, polyarthritis nodosa type of vasculitis. So all these autoimmune conditions can lead to peripheral ulcerative keratitis. Okay, now coming on to the clinical features of peripheral ulcerative keratitis. I have already told you, periphery पे होगा, epithelial defect होगा. Okay, epithelial defect होगा and scarring होगी. Okay, these are the main features for peripheral ulcerative keratitis, and thinning is also there. Peripheral cornea will be very thin, this part will be very thin, so perforation can occur easily, perforation can occur very easily. Okay, now what is the treatment for peripheral ulcerative keratitis? Although it is a keratitis, but the treatment, antibiotics are not included in its treatment. Antibiotics are not included. We'll give lubricants, will give steroids in it. Only keratitis in which steroid is the first line agent. Steroids, immunosuppressive agents. Okay, so these are all are the treatment for peripheral ulcerative keratitis. Okay, now we come on to the Murren's ulcer. Murren's ulcer is very much like the peripheral ulcerative keratitis, but with no underlying cause. It is the diagnosis of exclusion. If in peripheral ulcerative keratitis we cannot find any underlying cause, then that is known as Murren's ulcer. Okay, then that is known as Murren's ulcer. Okay, now what are the features of Murren's ulcer? First one is the pain. There will be very much pain. Pain is out of proportion to the disease. मतलब symptoms will be, signs will be very less, but pain will be very much. Okay, and overhanging edge of the ulcer. Okay, limbitis will be present in both, but scleritis is absent. Scleritis will not be there in Murren's ulcer, but it will be there in PUK, in peripheral ulcerative keratitis associated with autoimmune disease. Scleritis can occur, but it is not there in Murren's ulcer. Okay, so these are the main 3 differentiating points. I'll just repeat three differences between PUK and Murans ulcer. In PUK there will be pain will be very less, but it will be very much in Murans ulcer. Okay, cause it will be there in PUK but not in Murans. Okay, scleritis, it will be there in PUK and it will not be there in Murans ulcer. So if any patient comes to you with the peripheral thinning epithelial defect and you are confused between PUK and the Murans ulcer, so these features can help you differentiate between the PUK and Murans ulcer. Okay, fine. Now treatment is almost same as that of PUK. It will be lubricants, steroids, immunosuppressive agents, but in this pain will be very much, so NSAIDs can also be given. Okay, fine. Now this is the most hateable and the difficult part of the cornea. People at UG level usually hate reading corneal dystrophies, but I just want to give you the overview of the corneal dystrophies because this is a very vast topic, but I'll give you some overview so that if any question come in your exam you can easily tackle that question. Okay, but you have to take part in the discussion. Okay, you people are not taking part in the discussion, so you have to tell me the answers. Okay, the questions I am asking along with the discussion, you have to tell me the answers. Okay, so the definition of corneal dystrophies. Can anyone tell me the features of corneal dystrophies? Any one of you? Adyut, Devansh, anyone? Anyone there? Please tell me the features of corneal dystrophies. These are the bilateral conditions. Okay, hereditary conditions. Hereditary conditions bilateral होती हैं and no effect of environment on them. No effect of environment on them. Okay, these are the bilateral and hereditary conditions of the cornea which have no effect of environment on them, and these are progressive. Sorry, these are non-progressive. Okay, these are non-progressive bilateral and hereditary conditions. Okay, now there are dystrophies also and there are degenerations also. Now we have to differentiate between dystrophies and we have to differentiate between dystrophies and degeneration. Okay, how we can differentiate? How can we differentiate? Anyone having any idea? Dystrophy and degeneration. Example of degeneration is arcus snellis. This तो you have heard ना, arcus snellis gerontoxon. And spheroidal degeneration, corneal farinata, BSK, band shaped keratopathy. These are the examples of corneal degeneration. Now how can we differentiate between corneal dystrophy and corneal degeneration? Now the laterality. First one is the laterality. These are bilateral and these are unilateral mostly. Okay, and hereditary. These are hereditary but these are not hereditary. Environmental factors will not have any effect on dystrophies but they will have effect on degenerations. Okay, site. These are mostly central and these are mostly peripheral. Okay, so laterality, bilateral, hereditary, effect on dystrophies, not on degenerations. Environmental factors, no effect on dystrophies but have effect on degenerations. And site, these are central, dystrophies are central. Okay, and degenerations are peripheral. So blood supply has effect on peripheral degenerative lesions, no effect of vascularization on dystrophies. Okay, as Limbal vessels are no more nearer to the peripheral part as compared to the central part. So vascularization, limbal vessels will have effect on the degenerations but no effect on dystrophies. Okay. Now inheritance of dystrophy. You people don't have to go in detail of the dystrophies, but you have to know the superficial part, which dystrophy is autosomal dominant, which dystrophies are autosomal recessive. So here I just want to tell you that all dystrophies are autosomal recessive, but there are 4 exceptions. There are 4 exceptions. All the corneal dystrophies are autosomal recessive, but with 4 exceptions. Okay. 4 exceptions are: first one is the macular corneal dystrophy. Second one is CHED. Third one is gelatinous drop like dystrophy, GLDL, and fourth one is Lish corneal dystrophy. Fourth one is the Lish corneal dystrophy. First 3 are, all the corneal dystrophies are autosomal dominant. Okay, I want to correct here. All the corneal dystrophies are autosomal dominant except for the first 3, which are autosomal recessive, and Lish corneal dystrophy is X-linked dominant. Okay, so from now on there should be no confusion in the inheritance of the corneal dystrophies. Okay, all the corneal dystrophies are autosomal dominant except the macular dystrophy, CHED, GLDL, and Lish corneal dystrophy. Macular, CHED, and GLDL are autosomal recessive, but Lish corneal dystrophy is X-linked dominant. Okay. Okay, now coming on to the epithelial dystrophy. I'll just tell you the name of the epithelial dystrophies and little bit information about epithelial basement membrane dystrophy. Okay. Now, can anyone just enumerate? I'm asking for just enumeration. Can anyone just enumerate the epithelial dystrophies? Any one of you? Anyone? No one? Epithelial basement membrane dystrophy, Meesmann dystrophy. You have to just remember the names of this dystrophy, okay, not the details. Okay. Recurrent erosion dystrophy, epithelial recurrent erosion dystrophy, GLDL gelatinous drop like dystrophy, gelatinous drop like dystrophy. Okay, now coming on to the, I'll just go little bit detail of only epithelial basement membrane dystrophy. Epithelial basement membrane dystrophy, this is the autosomal dominant type, already discussed. Okay, now there are 5 F's for epithelial basement dystrophy. Epithelial basement membrane dystrophy can be covered in 5 F's, more common in females around 50 years of age group. Okay, and 15% prevalence, and if epithelial defects are present in some conditions, then 50% of those conditions will have epithelial basement membrane dystrophy as their cause. So 50% cause in epithelial erosions. Okay, so females 15% prevalence, and if epithelial erosions are present, then 50% of them will be having epithelial basement membrane dystrophy as their cause, and it is pass positive. It is pass positive. Okay. Now for the treatment, as epithelial. Now I just want to tell you the synonyms also. Okay. Ground glass dystrophy. Okay. Now the treatment for epithelial basement membrane dystrophy, we have to protect the epithelium. Okay, we have to make sure that epithelium is healing. Okay, for that we can give lubricants, and as epithelium is constantly getting eroded, so we have to protect the epithelium from getting eroded. For that we can place the bandage contact lens over the cornea, and another we can give hypertonic saline, because as epithelium is defective, so corneal thickening can occur due to the excessive accumulation of the fluid in the cornea. So to remove that excessive fluid from the cornea, we can use the hypertonic saline, that is Hypersol. It will take out the water from the cornea. Okay. Now second class of the dystrophies is Bowman's and anterior stromal. Can anyone just enumerate the names of Bowman's and anterior stromal dystrophies? Anyone? These are Rees-Buckler, Thiel-Behnke, lattice corneal dystrophy, and granular. Okay, we'll discuss only these two in short detail. Okay, Rees-Buckler and Thiel-Behnke, all of them are autosomal dominant. Okay, this you have to remember, I have already told you. Now we'll discuss some details for stromal dystrophies. Now I'll just tell you the names of stromal dystrophies first, and then we'll together discuss the anterior Bowman's and stromal dystrophies. Okay, stromal dystrophies name: macular dystrophy, okay, central cloudy corneal dystrophy of Francois, central cloudy corneal dystrophy of Francois, corneal stromal dystrophy. Okay, this is more important. It has autosomal recessive inheritance, rest all have autosomal dominant. Now we'll discuss some details about three dystrophies. Okay, these three dystrophies, I just want to tell you some details. First one is a lattice, other is macular, third one is granular. Okay, so I'll just discuss the deposition in these dystrophies and stain which is used to stain those depositions. Okay, so there is one mnemonic for it. It is Mun always get her countrymen in Los Angeles country. Okay, so Mun always is for macular, that is depositions are mucopolysaccharides and stained by Alcian blue dye. Stained by Alcian blue dye. M for macular, M for mucopolysaccharides, and A for Alcian blue. Okay. Now get her men. Get her men. So G is for granular, H is for hyaline deposits, and M is for Mason trichome. Stain used is Mason trichome. Okay, and in Los Angeles country. So L is for lattice, it will have deposition of amyloid, and it can be stained with Congo red. It can be stained with Congo red. Okay. So endothelial dystrophies, I'll just tell you the name of the endothelial dystrophies, not going into details. It is CHED, congenital hereditary endothelial dystrophy, Fuchs endothelial dystrophy, PPCD, posterior polymorphous corneal dystrophy. Okay. Now this is the last topic for today's discussion, that is corneal transplantation. Okay, so we'll discuss in short details for corneal transplantation. Okay. So what are the indications of corneal dystrophies? Can anyone just tell me the indications for corneal transplantation? Anyone? This is optical, therapeutic indication, optical indication, or tectonic indication. Tectonic. So optical is used to restore the vision. Main motive is to restore the vision, and therapeutic main aim is to eradicate the disease process. And tectonic is to maintain the integrity of the cornea. To maintain integrity of the cornea. Okay. Now what are the prerequisites? Prerequisites for corneal transplantation. We need a trained personnel for for harvesting the cornea. Firstly, we have to harvest the cornea and then we'll do the transplantation. So we need trained personnel for harvesting the cornea, and the time of death and the duration between the time of death and the harvesting of the cornea should be less than 6 hours. Okay, and any age group can be chosen for corneal harvesting. Okay, any age group can be chosen. Duration between the death and the harvesting of the cornea should be less than 6 hours, and trained personnel should be there for the harvesting of the corneal tissue. Okay. Now what are the contraindications? In what conditions corneal harvesting cannot be done from the dead body? Okay, from the dead. What are the conditions in which corneal harvesting cannot be done? Okay, if a person who has died, they have active disease like hepatitis B, hepatitis C, HIV, okay, miliary TB, rubella, okay, and prions disease, Alzheimer's disease. So in all these conditions, if they are present in the diseased person, then these are the contraindications for corneal transplantation. Any ocular pathology if present, like ulcer, cancers like RB or melanoma, okay, cancers, RB or melanoma, active disease like ulcer, and most important these days is, not these days but in the previous 1.5 year, coronavirus. So these are the contraindications for harvesting the cornea. Okay, now when we have harvested the cornea, we have to store that cornea. We cannot immediately use that. We can immediately use the cornea, but for transportation we have to use some storage media, and for keeping the tissues in the eye bank we need some storage media. So there are 3 kind of storage media: for short interval, for intermediate interval, okay, and for long term. Can anyone just tell me the name of the medias? For short term, what medias we can use for corneal storage? Moist chambers, MK media. For intermediate, MK media can be used for 4 days. That is, cornea preserved in MK medias have to be used within the 4 days of the corneal harvesting. And if the corneas are stored in cornisol, they can be used till 14 days. And for the long term, cryopreservation. Okay, if we are cryopreserving the cornea, then we can use it till 1 year or so. Okay. Now, what are the types of corneal transplantation? Full thickness corneal transplantation and partial thickness corneal transplantation. Okay. Now you have to just tell me the types. Okay. Total and partial. Total is full thickness corneal transplant. Epithelium, Bowman's, stroma, desmet and endothelium, all the 5 layers of the donor have been all the 5 layers of the host are replaced by the donor cornea. But in partial thickness, only some part of the cornea of the host is replaced by the donor cornea, not the full thickness. Okay. Now anterior keratoplasty and posterior keratoplasty. Okay. In anterior keratoplasty, Bowman's or stroma are replaced. Okay, and in posterior keratoplasty, endothelium is replaced. Okay, so if Bowman's and stroma are replaced, that is done under anterior keratoplasty, and if endothelium is replaced, then it is done under posterior keratoplasty. Okay. Now anterior lamellar keratoplasty. Okay. Now what are the indications of anterior lamellar keratoplasty? Can anyone just tell me? In this, I will give you one hint. Only stroma or Bowman's are diseased. Endothelium and desmets, they are absolutely fine. These both are diseased. We have to replace only stroma and Bowman's. So now you have to tell me those conditions in which only Bowman's or stroma are involved. Can anyone just tell me those conditions? Indications. Keratoconus. Anyone was just telling me keratoplasty as a treatment for keratoconus. So anterior lamellar keratoplasty can be done in keratoconus. Any dystrophies which are involving only Bowman's and stroma, in those dystrophies we can do anterior lamellar keratoplasty. So what are the types of anterior lamellar keratoplasty? It is SALC and DALC. In SALC, only epithelium, Bowman's and superficial part of stroma are replaced. Okay, not the whole stroma, but only superficial part of stroma is replaced. Yes, also you are right. Opacities can also be there, nebular and macular. Right, very much right. Only if they are involving the Bowman's and the stromal part. Okay, not the full thickness. Okay. So if epithelium, Bowman's and superficial stroma are replaced, then that is known as superficial anterior lamellar keratoplasty. And if posterior stroma is also replaced, then that is known as deep anterior lamellar keratoplasty. Okay, this is till 130 to 150 micrometer thickness, and if more than that, then we have to do the DALC. Okay. Posterior lamellar keratoplasty, there are three surgeries that we can do in posterior lamellar keratoplasty. First, the indications. Only Bowman, only endothelium and desmets, they are diseased, only they are having the pathology. In aphakic and pseudophakic bullous keratopathy, endothelium is severely compromised in these conditions, and in dystrophies involving endothelium and desmids, endothelium dystrophies like CHED, Fuchs and PPCD. Okay, I have already told you these things. Now coming on to the types of posterior lamellar keratoplasty. These are PDEC, DSEC, DMAC. Can anyone just tell me the name? Can anyone just tell me the full form of this? This is predesmatic. This is predesmatic endothelial keratoplasty. It is desmet stripping automated endothelial keratoplasty. It is desmet membrane endothelial keratoplasty. Okay, in this the donor cornea will have posterior stroma, desmet membrane and endothelium. Okay, these all will be present in the donor cornea, but in DMAC only desmet membrane and endothelium will be present in the donor cornea. Okay, and in PDEC, that is predesmatic, so in this Duas layer, desmet membrane and endothelium will be present in the donor cornea. So I'll just repeat, in PDEC only Duas layer, desmet membrane and endothelium will be present, and in DSEC only posterior stroma, desmet membrane and endothelium will be present, and in DMAC only desmet membrane and endothelium will be present in the donor cornea. Okay, now what are the complications of the corneal transplantation? Okay, first and foremost is the graft rejection. If there occurs graft rejection in the cornea, cornea will be compromised and it will not serve its purpose, and that condition is known as graft rejection. Okay, persistent epithelial defects. Okay, glaucoma can occur, and in partial keratoplasties, interface will be there na between the donor cornea and the host cornea. So interface haze can occur in partial keratoplasties, interface keratitis, and interface fluid can be present in the partial keratoplasties, and of course infections. Any keratitis can reoccur or can be primarily affect the graft. Okay, see, so these are all the complications of the corneal transplantation. So friends, that is all for today. I hope you liked the session. So please give your reviews in the comment section below, and you can give me suggestions also on how we can improve these sessions, and you can also tell me the topics that you want me to discuss in subsequent sessions. So that is all for today. Thank you so much, and I hope you will like, and if you have liked my session, please do like the channel, please do subscribe and press the bell icon for more notifications. And lastly, I just want to thank Dr. Himanshu Gupta for giving me the opportunity to take a session on his channel. But please give your feedback in the comment section below, and the topics that you want me to discuss in subsequent sessions. So please leave your opinions in the comment section below. Okay, thank you so much. That is all for today.